Welcome to Eye Experts University. I'm Dr. Eli Sluch, and today we'll be talking about how baby eyes are made. In this topic, we're going to talk about the proteins, growth factors, and homeobox genes, and how they direct the neural crest cells and other embryological structures into forming the eye shape. We'll discuss how those shapes actually form, and then we'll see what happens when those things go awry. The three main factors of eye development are growth factors, which are chemical signals that regulate the cells. The homeobox genes, these are the master transcription factor genes that regulate organ development. And neural crest cells, which form most of the connective tissue of the eye. So growth factors are basically proteins that bind cell receptors to cause the cell to do different things. The source of the growth factors is from the maternal mRNA until the embryonic genome activates and starts making their own growth factors. The growth factors are the ones that help regulate the homeobox gene expression. The key growth factors for eye development are fibroblast growth factor, which helps stimulate the inner optic cup and forms the neural retina, lens epithelium, and lens fibers. TGF-beta, which regulates neural crest cell migration, and IGF-1, which promotes mitotic activity and differentiation of the lens epithelium. Homeobox genes are the master switches. They're the ones that activate and express the other genes necessary for development. They are activated by the growth factors and retinoic acid, which is vitamin A. That's why if you take too much vitamin A or retinol when you're pregnant, it's going to cause malformations because it's going to overstimulate the homeobox genes. The main homeobox genes for the eyes are PAX6, which affects the lens and the optic vesicle, HOX8 for the corneal epithelium, and HOX7, which is the ciliary body. The neural crest cells are these really cool stem cells that arise from the neural tube, and then they migrate and basically form the head. They will form the maxilla, the mandible, and the diencephalic structures, and the eye is part of the diencephalon. Because everything is a test question, other layers also do some stuff. So specifically, the neuroectoderm is what forms the optic cup, which is part of the neurosensory retina, the RPE, and the iris pigment epithelium. So when you think uvea, think neuroectoderm. The neural crest cells form the cornea, the best part, the choroidal stroma, iris connective tissue, and the ciliary ganglion. So think of collagen, think neural crest cells. The surface ectoderm forms the lens placoat. So it forms the skin and the lens because the lens kind of pinches off and goes on the inside. Otherwise, think conjunctiva and eyelid skin. Mesoderm, think muscles. Mesoderm is what forms your extraocular muscles and your blood vessels. Neural crest cells form the cornea in the anterior segment, so when something goes awry with neural crest cells, you get anterior segment dysgenesis, which is Axenfeld-Rieger syndrome and Peters anomaly. So you get corneal malformations, you get iris malformations, you get glaucoma because Schlemm's canal doesn't form, just depending on which type of the neural crest cell wave got affected. There are some systemic diseases that can also cause neural crest cell problems, like cleft palate, but those are not eye related. So now we're gonna move into phase two, which is the actual embryogenesis. So as we know, the egg gets fertilized, it starts to grow, it goes to the morula, blastula, and then gastrula phase. And then it starts getting bigger, forms the neural tube, and starts generating all the cells. Now that the neural tube has formed, we get to the exciting part of eye development around week 4. In the beginning, the optic sulci appears, and then towards the end of that week, the lens placoat forms. So remember, there's two types of ectoderm, the surface ectoderm and the neuroectoderm. The lens placoat is formed from the surface ectoderm. That's the part that's going to form the eyelids, the conjunctiva, and because the lens pinches off the surface ectoderm, that's how the surface ectoderm actually gets to go inside the eye, past all the structures, like a droplet dropped in a bucket. Now, the neuroectoderm is behind the eye. So that's the part that's going to form the optic nerve and it's going to form the uveal tract. Now, the cup needs to kind of close on itself like a pincher, and if it doesn't close, that's how you get a coloboma. So, this is a coloboma. They always occur at 6 o'clock inferiorly because the cup basically closes from the top down, and down is where it doesn't finish fusing. So, it can affect the nerve, the retina all the way through, and the iris because that's the uveal tract. So as we've learned, in the fourth week is when the eye development begins. In the second month, things get more busy. We start getting retinal differentiation, we start seeing the lens vesicle, the hyaloid artery forms, and we start seeing axons from ganglion cells migrate to the optic nerve. In the third month, the retinal cone and rod precursors start forming, and the sclera kind of starts taking shape. Over the next 6 months is when the rest of the eye forms. Specifically, what's important here is if you look at what happens to the retinal blood vessels, you will see that the retinal blood vessels reach the periphery by 9 months in birth. So the whole 6 months, things are developing, they're growing. So you can see that premature babies, when they're born, their retina is not done. Many of the other eye structures are not done either. And this is why the earlier they come out, the higher the chance that they will develop retinopathy of prematurity just because the retina is not done yet. So remember, the neurosensory retina and the uvea form from neuroectoderm of the optic cup. This is the specific sequence of the events, but if you look on the right, this is retinopathy of prematurity. You will see that thick line in the periphery, and you see those angry blood vessels going through it. That is a line where the development kind of stopped forming, and the retina is now growing the wrong way and is getting angry. Now, the fovea forms in the center, and it forms fairly early. It's established by 15 weeks. And then over time, it starts thinning out because remember, in the center, we don't want anything over there besides the photoreceptors. So by 8 months, there's only two ganglion cell layers remaining. Now, as we remember, the RPE is the supportive structure of the retina. If it doesn't form well, the rest of the retina won't. And the cool thing about the RPE is it is the first structure in the body that actually produces melanin. So the optic placode starts to form, and by around 10 to 12 weeks, the axons actually start forming the optic nerve and have almost 1.9 million axons. Then that number peaks at 16 weeks and then starts decreasing closer to a million over time. So the axons are redundant, but once they eventually decide where they're going to go, they do get trimmed down. Now, myelination starts at the seventh month at the chiasm and then proceeds towards the eye. As we remember, the lens forms from the lens placode of the surface ectoderm. Starts around the end of week 4, and then by around day 45, we form our embryonic nucleus. Now, the lens retains its stem cells that are preequatorial, and they continue to divide over time. So when you look at a lens, you will see the Y and inverted Y sutures. That's the embryonic nucleus. That's why they're called embryonic sutures. And then all the layers after it, like an onion, are formed over time as we age. Now, the vitreous has a pretty complicated three-stage development, and then it doesn't do much after it's formed. But the main thing is here is that 3 stages. The tertiary vitreous forms around the third month, and the cloacae canal that you see is a remnant of the primary vitreous. So the hyaloid vascular system forms during development and completely regresses over time. It kind of forms this primitive dorsal ophthalmic artery. Now, over time, it starts atrophying and completely disappears by the 8th month. If it doesn't, though, then you can see either a Mittendorf dot, which is a tiny little remnant in the back of the lens, or you can see what's called a Burgermeister papilla, which is a vascular stalk coming off the optic nerve. So the uvea is formed from neural ectoderm, but the blood vessels are from neural crest. So neural crest cells start condensing around the optic cup and then start forming the choriocapillaris and the other blood vessels. So the cornea forms from neural crest cells and has this very strange multi-wave development. For some reason, we form the corneal endothelium first, and then we start filling in the stroma, and then Bowman's membrane forms from corneal epithelium around the 4th month. Now, the sclera in lamina cribrosa, the part that wraps around the optic nerve, mostly forms from neural crest cells. Doesn't really do much. It just forms a bunch of collagen. That's a picture of a sclera. So the anterior chamber starts forming from neural crest waves. This is important because, as you can see, the anterior chamber forms over a pretty prolonged period. Starts at 7 weeks. By 15, we start seeing some structures. The angle deepens by the 3rd month. and it continues to develop and deposit even all the way up to the eighth month. So there's a lot of time to damage the anterior chamber and the drainage system of the eye, thus leading to different types of glaucoma. So CYP1B1 is a glaucoma mutation that causes angle agenesis, but you can also get it from other causes. That's why glaucoma is multifactorial, just because the development time is so long and so many genes are involved. So Schlemm's canal forms as a venous plexus at the end of the third month from mesoderm, because that's what forms our blood vessels, and initially functions as a blood vessel until it starts forming this kind of juxtacanalicular tissue and then eventually starts doing aqueous circulation. Iris development again starts at the sixth week. It's early because remember we're growing from the optic cup. So the ciliary epithelium forms from a neuroectoderm as it folds on itself. That's why there's two layers. And the interesting thing about the ciliary body is that the ciliary muscles are formed from neural crest. Now, this is important because most muscles are formed from the mesoderm, but the ciliary body is an exception that those are specifically neural crest in origin. Blood flow to the eye starts early at 6 weeks, and retinal vascularization starts in the fourth month, continues all the way to birth, and actually the adult vascularization pattern finishes after birth, about 3 months afterwards. It takes a really long time to vascularize the retina. Just look at all those blood vessels. Now, the neural crest cells form the orbital bones, except for the sphenoid, because the sphenoid also has a mesodermal component to it. The extraocular muscles are formed from the mesoderm layer, and the eyelids are formed from surface ectoderm. Now, this is actually pretty interesting. The eyeballs actually align on where they are in the head. So first, the angles between the eyes is almost 180 degrees. It would kind of look like a cow, where the eyes are on each side. Now, by 3 months gestation, though, the angle decreases to just 105 degrees, and then by birth, it's 71. That's the angle between the optic nerves, basically. Now, the repositioning is driven by head enlargement, brain growth, kind of pushing things in, and just overall facial remodeling. Now, what's interesting is that the orbital volume at birth is about 10 milliliters, and by adulthood, we reach about 30. So that is a significant change because the eye does not triple in size. Now, remember how we talked about the gene mutations can cause different eye problems? So these are the genes that are very relevant to eye development and are very, very testable. So PAX6 is the one that causes aniridia, Peters anomaly, and accidental rigor, so anterior segment dysgenesis. PAX2 causes a coloboma. Sonic the Hedgehog, as you can remember this creepy hedgehog, causes cyclopia and prosencephaly. PIDX2 is also associated with Peters anomaly and Riger anomaly, so another version of anterior segment dysgenesis. FOXC1 is Axenfeld-Rieger syndrome, also anterior segment dysgenesis. And CHD7 is the Charge syndrome, which is coloboma, heart, and atresia. Now, while we're aware that gene mutations can cause problems, as discussed in the beginning of this lecture, we can also affect the genes externally, such as vitamin A. So the most common and most important one is alcohol. Alcohol changes the way the gene transcription operates and can cause mutations. Thalidomide, we've all heard the story, causes severe limb abnormalities, again because it affects limb development. Now, the earlier you get exposed to the teratogen, the worse it's going to be, just because you have affected the sequence at an earlier stage. So the butterfly effect from it is going to be bigger. Fetal alcohol syndrome is a very sad and very preventable cause of congenital anomalies. Prenatal exposure of the embryo to alcohol, which is a toxin, causes delayed growth, mental retardation, behavior problems, and some congenital malformations. Characteristic facial features include a narrow forehead, short palpebral fissures, a small nose, small midface, a characteristic long upper lip with a deficient philtrum. From an eye standpoint, you can get some strabismus, blepharotosis, some cataract glaucoma, some strange eye malformations, basically. Now, this all sounds like something we've talked about before, and this is related to impaired neural cell migration because it is responsible for the face and many other eye developments.